We'll start with this antiplatelets. Again, a very, very, very high yielding topic for INICT, especially for INICT. So, but chances are very high. Again, he may ask image based things. So, here in antiplatelets, we have these three categories. One is thromboxane A2 synthesis inhibitor, and we have ADP receptor antagonist or P2Y12 inhibitor, and we have glycoprotein 2B3 antagonist. So these are the things. Image, he may ask you like, he might be focusing on this one. He may ask which of the following drug acts at this step, or which of the following which of the following statements are true about the drug acting at that step. So the drug acting on COX, that is aspirin. So aspirin, it is going to inhibit COX. Remember, very, very, very important, it is going to inhibit irreversibly. It is going to inhibit irreversibly. That's all about this aspirin part. Now come to ADP receptor antagonist or P2Y12 inhibitors. So this also we have dealt this one. These are the grill drugs. These are the drugs containing grill. You see, clopidogrel, prasugrel, clopidogrel, prasugrel, can grill or grill, ticagrelor or grill. So the drugs containing grill, they are ADP receptor antagonists. But these clopidogrel and prasugrel, these are the irreversible, and cangrelor and ticagrelor, these are reversible. Irreversible and reversible. And that's all about this ADP receptor antagonist. And this is what I told you multiple times. Clopidogrel point. Clopidogrel question. We know clopidogrel is a prodrug, right? Clopidogrel it is a prodrug. It gets converts to, it is a inactive one. It gets converts to active with the help of CYP2C19. This is what omeprazole. Fantastic, fantastic, Shruti. This was a question asked almost like in the last 20 exams from 2022, 2024, almost like INICT and what you call NEET, almost like 7 or 8 times this question was asked. And that one is inhibited by omeprazole. So now, if you combine clopidogrel and omeprazole, what is the consequence? It will not get converted to active. So no activation of this clopidogrel. So antiplatelet effect will not be there, and patient might be having recurrent attacks. That is the number one. What is the causage of recurrent attack? Because omeprazole is the one which is going to inhibit CYP2C19. Then what if patient is having GERD as well as or like some reason for taking antiplatelets like MI? Then what is a safe PPI here in this condition? As already we discussed, panto. Fantastic, Swati. That is pantoprazole. Asked panto. Fantastic, fantastic, fantastic. That is panto. This is what a very important drug interaction. Very important drug interaction. So that's all about this ADP receptor antagonist. Now come to the next one, glycoprotein 2B3A. Glycoprotein 2B3A inhibitor, glycoprotein 2B3A antagonist. We have three drugs, that is eptifibatide, abisiximab, and tirofiban. And again, among these, there is one point here with abisiximab. All are reversible. This is irreversible inhibitor. And then this is given safe in, this is safe in renal failure. That's all. So abisiximab, it is irreversible inhibitor and it is safe in renal failure. These are because this is a question, this is also a question asked previously. Which of the following glycoprotein 2B3 inhibitor which is safe in renal failure? Because this abisiximab, it is eliminated non-renally. So that is, it is safe in renal failure. That's all about antiplatelet drugs. Drugs, classification, inhibitor, and their points also. So this part, it is third one, glycoprotein 2B3 inhibitors, ADP receptor antagonist, and then this one, that is aspirin. That's all about this part. This is one with respect to picture. This is one, this is two, and this is three. That's all. That's all about this antiplatelets. Now come to the next one. Purple toe syndrome. A very important, this purple toe syndrome. This is due to, already we know that is due to warfarin. The causative drug is warfarin. No, Suhan, purple glove syndrome is phenytoin. Purple toe syndrome is warfarin. That is what you should not get confused. Purple glove syndrome is phenytoin. Purple toe syndrome is warfarin. It is due to what? It is due to deposit, what you call liberation of this cholesterol emboli from atherosclerosis plaques. It is due to cholesterol. It is due to cholesterol embolization from atheroscleromatous plaques. That is what the reason for purple toe syndrome. Next, here comes a blood, a very, very cholesterol, fantastic, Mahariharan, fantastic. So, very important antidotes. Heparin antidote is protamine sulfate, and warfarin antidote is vitamin K. Vitamin K. Next, rivaroxaban antidote is andexanet alpha. Here we have rivaroxaban XA, 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 andexanet alpha. Next one, dabigatran antidote is idarucizumab. 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 So these are the antidotes of these what you call anticoagulants. And then the very important one in anticoagulant, that might be parenteral, that might be oral, lab monitoring. Lab monitoring is required. Required for what? Lab monitoring is required for heparin, warfarin, and as well as direct thrombin inhibitors, which are parenteral. All these rudin, all these bivalirudin, high, all these rudin derivatives. Okay, all these rudin derivatives. This is what a very important lab monitoring. Heparin, warfarin, direct thrombin inhibitors, which are given parenterally. Parenterally. That's all about the relevant points related to these blood chapter and this antidotes. Antidotes are very important. Lab monitoring is very important in this blood. Now, come to one more thing, that is fibrinolytics. So we know this plasminogen, it gets converts to plasmin with the help of one thing, which is tissue plasminogen, tissue plasminogen activator. Tissue plasminogen activator. That plasmin, it breaks the fibrin into fibrin degradation product. That's how this fibrinolysis happen. Now, there are the drugs which promotes tissue plasminogen activator, and there are few drugs which inhibits this tissue plasminogen activator. Those promoted drugs, this is what? This tissue plasminogen activator promoting drugs, they are nothing but streptokinase, urokinase, reteplase, alteplase, Surat, fantastic, fantastic, Archana, Surat, alteplase, tenecteplase. So you can remember all these drugs with a mnemonic, just Surat, streptokinase, urokinase, reteplase, alteplase, tenecteplase. So Surat drugs, Surat, sorry, these Surat drugs, they promote tissue plasminogen activator. They promote tissue plasminogen activator. Now, okay, sir, you told about these are the fibrinolytic drugs. Then is there any relevant point about those drugs? Yes, you can write it down here. Just write it down. So just write Surat, because already we have know the abbreviation. So here, these two, these are fibrin non-specific. These three are fibrin specific, fibrin non-specific, and fibrin specific. Then here bleeding, it has high risk, high risk of bleeding. Next, what about these fibrin specific drugs? Of course, here also bleeding is present, but low risk. Low risk of bleeding. Low risk of bleeding. And among those, if he asks you which of the following has highest fibrin specificity, that is T-neck-Tepless. It has very highest fibrin specificity. Highest fibrin specificity. Next one. That T-neck-Tepless, it is associated with least incidence of non-cerebral bleeding. It is associated with least incidence of non-cerebral bleeding. That's all. These are the things which are very important. And then there is one more point with the TNET place where we'll be giving single IV infusion. That's it. That's it. So TNET place single IV, single IV bolus. It's not infusion, single IV bolus. Highest fibrin specificity associated with least non-cerebral hemorrhage. These are the 3 points related to peculiar points related to TNET. So that's all about these drugs. Now, what are the drugs which inhibiting that one? Those are tissue plasminogen activator inhibiting drugs. They're antifibrinolytic, tranexamic acid and epsilon amino caproic acid. Tranexamic acid and epsilon amino caproic acid, they inhibit this one. They inhibit, and they are contraindicated in hematuria. They are contraindicated in what? Hematuria. Because it may lead to renal failure. It may lead to the clot deposition, and it may lead to that renal failure. That's all about these fibrinolytics. That's all about these fibrinolytics drugs and their peculiar points. Now come to the next one. Dyslipidemic drugs are very important for INI-CT. Almost like every year, because they conduct in May and November, definitely one session they are going to ask about this dyslipidemic drugs. Nothing, just names. He will be mentioning which of the following is a PCSK9 inhibitor, which of the following is a MTP inhibitor, which of the following is a what you call maybe cholesterol absorption inhibitor, in that way. So he is going to ask you drug, how it is going to act. Very important one for INI-CT. So chances are again there he might be focusing one picture, or he will just focus on something else, and he will ask you which of the following is a drug. So you see here we have in the liver from acetyl coenzyme A, finally we are getting cholesterol. So that synthesis that is inhibited by HMG CoA reductase inhibitors. That is inhibited by HMG CoA reductase inhibitors. We know all these drugs are what? Ending with the statins. Of course, not all statins. There is some exception. Already I told you cilastatin, that is combined with antimicrobial agent, right? Statins. And what are the relevant points about these statins? Generally, statins are taken at a night time, but there are two statins which we can take at any time. They are atorvastatin, rosuvastatin. These two statins are most effective statins, and they're taken at any time. Taken at any time. Remember that. They can be taken at any time. Atorvastatin, rosuvastatin are most effective, and they can be taken at any time. Fantastic, fantastic. And then there is one more one peculiarity with the statins. What is that peculiarity? Second point, just remember that sleep. The statins which produces sleep abnormalities, they are the drug starting with SL. Simvastatin, lovastatin. So these are the drugs which produces sleep abnormalities. Fantastic. Simvastatin, lovastatin, fantastic, Hariharan. And those two are the drugs which are prodrugs. That's all about statins. Exactly, it is going to cause a very characteristic ADR, myalgia, right, Shruti? Myalgia. So those things, myalgia, everyone will remember. But these are the two peculiar points: most effective statins, and the statins which can be taken at any point of the time, and the statins which are prodrugs, and the statins which produce sleep abnormalities. These are the four characteristic points related to these statins. Yes, they are going to cause myalgia, and it increases with the fibrates. That's we know. Next one, that cholesterol, it is getting absorbed from the intestine, right? It is getting absorbed from the intestine. This is what it is getting absorbed from the intestine. That step is inhibited by one thing known as ezetimibe. That step is inhibited by ezetimibe. That is what here, cholesterol absorption inhibitor, that is ezetimibe. So what it is going to do, ezetimibe is going to inhibit Niemann-Pick, that is NPC1L1 transporter. It is going to inhibit one transport, that is NPC1L1. That is the one which is responsible for a transport of cholesterol. It is going to inhibit that ezetimibe. So that is the first one. This is everything is like a very high yielding on all the previous year questions and as well as topics. Now let's see. We have done with this part also. Then finally, it is going to form the bile acids. Those bile acids, they go into the intestine, they does their respective function. After that bile acids, again they get reabsorbed. That reabsorption is inhibited by bile acid binding resins. That step. So bile acids inhibited by bile acid binding resins, and these are the drugs. Again, you need not remember the drug name for your exam. You can see these are all the drugs starting with the chol. Cholestyramine, cholecalciferol, cholestyramine. Right? These are the bile acid binding resins. These are the bile acid binding resins. Next one, PPAR alpha agonist. Remember, this is alpha. These are all fibrates. Gem fibrosyl, phenofibrate. They contain this fiber in its name, fibrosyl. This is what. So the mechanism of action of gem fibril is stimulation of lipoprotein lipase. Stimulation of lipoprotein lipase. So that is what PPAR. Remember, PPAR alpha agonists are fibrates. And just tell me, PPAR gamma agonist. PPAR gamma agonist, they are nothing but, no, not tell me sartan, ma. Not tell me sartan. PPAR gamma, they are glitazones. Pioglitazone, rosiglitazone, anti-diabetic drugs, fantastic, fantastic, fantastic. They are glitazones, fantastic, fantastic. They are glitazones. Next one, very important, PCSK9 inhibitors. PCSK9 inhibitors. We have these two, and the recent one also. We have alirocumab, evolocumab. These are the monoclonal antibodies, alirocumab and evolocumab. Yes, inclisiran, fantastic, Hariharan. This inclisiran, there is a newer one, might be expected one for your next coming INICT exam. Inclisiran, it is a, see, what is this inclisiran? It is a small interfering RNA. This is small interfering RNA. The name itself, it is saying it is a small interfering RNA. It is a small interfering RNA. Okay, fine. What it is doing? These PCSK9 inhibitors, they increase the LDL receptors, reduce the production of PCSK9. Fantastic. If they reduce the production of PCSK9, it is going to increase the LDL receptors. So it is going to increase something. What it is going to increase? Increase something at a liver. Li means liver. It is going to increase something. What it is increasing? It is going to increase LDL receptors. It is going to increase the LDL receptors at the liver. So if it is increasing LDL receptors at the liver, it is going to take all the LDL. That's how it is going to act. So PCSK9 inhibitors, they are going to increase the LDL receptors. So that's how inclisiran might be very important, might be the expected one for the next coming INICT, this inclisiran. Next one, MTP inhibitor, lomitapide. It is a microsomal triglyceride transfer protein inhibitor. So there is no transfer of triglycerides, lomitapide. This is what lomitapide, MTP. MTP inhibitor, lomitapide, MTP inhibitor. Next one, apart from these things, we have few other things also. Apolipoprotein B inhibitor. We already know that is mypo Hypomersen. Fantastic. Hypomersen, this already we have discussed this one. Hypomersen, it's like 100. So apolipoprotein B100 inhibitor. Apolipoprotein B100 inhibitor, Hypomersen. IPO, you can remember it like 100. Next one, angiopoietin. Angiopoietin like protein inhibitor. This is Evinacumab. Evinacumab. The name itself, angiopoietin. AN is nothing but angiopoietin. I means inhibitor. Angiopoietin inhibitor. Don't get confused between evolocumab and evinacumab. Don't get confused. This is the name itself. Evina. AN angiopoietin I inhibitor. Angiopoietin inhibitor. The other one, which is almost similar to one, is like PCSK9 inhibitor. That's all about dyslipidemic drugs. A very, very, very important slide. This is 27th slide. Dyslipidemic drugs. Clear, everyone? Up to this CVS part. We have done this entire CVS, blood and as well as drugs related to dyslipidemia. Fantastic, Alex. Can we go to the next one? Fantastic, dear. Fantastic. Those things, yeah, I have given those things. Yeah, I'll come back to those. I will come back to those things in what you call vital capsules. We have time. We have time. We'll be discussing them. No worries. No worries. I given those points. Just drug and how it is going to act. Everything I have given in vital capsules also. No worries. It is there. Fine. Now next come to drugs, anti-gout drugs. Next come to the drugs, anti-gout autocoids. So here, if you see these autocoids, it plays a very crucial role in NEET. It plays a very crucial role in NEET. This gout, rheumatoid arthritis, migraine, prostaglandins, NSAIDs, very crucial role in NEET exam, not in INICD. See, here there is increased purines. Increased purines. It is going to produce a hypoxanthine with the help of xanthine oxidase. It's going to form xanthines and it is going to promote the uric acid. That uric acid, what it will do, it will go and deposit in the joints and connective tissue, causing this gouty arthritis. Now, this is what happens here in our what you call body, human body. But in birds, it will not happen because that uric acid, it gets converts to allantoin with the help of one enzyme which is known as uricase. With the help of one enzyme that is known as uricase. So what they had developed, what scientists thought, okay, if we can develop a drug which is similar to uricase, that uric acid also will get converts to allantoin and it will get eliminated. That is what the drugs rasburicase, pegloticase, these two are uricase analogs. These two drugs are uricase analogs. So now let's see the drugs and their mechanism of action here. Allopurinol and febuxostat, they drugs inhibits xanthine oxidase. These drugs inhibit xanthine oxidase, febuxostat. Stat, that means it is stopping. What it is stopping? It is stopping the enzyme, activity of enzyme, which is xanthine oxidase. It is stopping xanthine oxidase. That's all. Next one, rasburicase, pegloticase. Already we have done with these two. They are uricase analogs. They are used for what? This rasburicase used for treatment of secondary hyperuricemia, that is due to drugs, especially cancer chemotherapy. Next, pegloticase useful for treatment of severe chronic refractory gout. Severe chronic refractory gout. This is what drugs and how they are going to act and what is the use. Now let's see if in your question, if they ask you acute gout, first line drug, it will be NSAIDs. Acute gout, first line drug, it will be NSAIDs. Yeah, yeah. It is indomethacin, we'll give NSAIDs. Then what about this colchicine? Colchicine is not a first line drug, it is a alternative one. Why it is an alternative one? Why it is not a first line drug? Because it is having drug very narrow therapeutic index. Example, very good, Hariharan. It is block microtubule. It is an anti-mitotic drug. This is a question asked multiple times. The anti-mitotic drug used in the treatment of gout, acute gouty arthritis, that is colchicine, anti-mitotic drug, colchicine. Why it is alternative? Because it is having narrow therapeutic index, low therapeutic index. That's all. That's all about these gout points. That's all about these gout points. So these are all the drugs and relevant points related to this gout. So chances are there he might be asking, he might be giving this kind of flow chart and he'll be focusing on these two, and he might be asking, so what are the drugs inhibiting this xanthine oxidase? So those kind of questions he may ask. Those kind of questions he may ask. Now let's come to the next part, antimicrobials. And again, as I always tell, CNS and antimicrobials, those two are the heroes in pharmacology, whether it might be NEET or whether it might be INICT. Multiple questions will be there. So here in this cell wall synthesis inhibitor, we have almost eight images. We'll cover all these images one by one, all the very high yielding images and very high yielding points related to that image and surrounding that topic also. The first one, cell wall synthesis inhibitors, and let's see one by one now. This already we have discussed this part. This is how the cell wall forms here. This is what a carbohydrate, N-acetylmuramic acid, N-acetylglucosamine, these are all carbohydrates and these are proteins. This is how he is going to give exact pictures he will be giving you, and he will ask you which of the following drugs blocks this, which of the following statements are true about the drugs blocking this. Here you see carbohydrate, they are joining. That is what we call glycosylation. That glycosylation that is catalyzed by transglycosylases, right? Next one, if you see again the same carbohydrate, protein. Here, nothing is happening with this part. Here, proteins are getting bind. That is what we call peptidation. That is catalyzed by transpeptidases. So, peptidation catalyzed by transpeptidases. So, what are the drugs inhibiting this transglycosylation and what are the drugs inhibiting this transpeptidation? This is what a very important one. This question was asked first. They used to ask statement questions. They have given image based. They have asked this image. They have asked this image too. Everything they have asked before also. Now let's see. Here you see transpeptidation. A very easy one. Just remember LAP. P means peptidation. LA means lactams. So beta lactams. Beta lactam, LAP, it is going to inhibit peptidase. Next one, penicillin, yes, fantastic, beta lactam. Next one, transglycosylases, obviously the other one, vancomycin. The other one, vancomycin. That's all. That's all about this part, which is what drug inhibits what. Remember LAP, lactams, peptidases, vancomycin, glycosylases. That's all about the cell wall synthesis inhibitors image. Now let's come to this part. So again, the same thing which I have discussed, vancomycin inhibit transglycosylation and beta lactams inhibit transpeptidation. That is what we have discussed. And trust me, INICT, they are more obsessed about vancomycin. They have asked everything about vancomycin. So vancomycin uses, there's a drug of choice for MRSA, and Enterococcus fecalis is an alternative drug, but generally we give penicillins along with aminoglycosides. But if patient is not responding, we'll go for this vancomycin. Next, pseudomembrane colitis. We'll be giving oral vancomycin in pseudomembrane colitis, which I'll be discussing in my next slide about pseudomembrane colitis. But is there any other points with vancomycin? Yes, definitely. This is a drug acting. This is a drug acting only on gram-positive organisms. Gram-positive organism, fantastic, Redman, yes, Diya, yes, Harini, yes, true. And what are the ADRs? It is going to cause nephrotoxicity, it is going to cause ototoxicity, and it is going to cause something known as Redman syndrome. That is like flushing. When the patient will be getting this Redman syndrome, not in a oral route, it is given, if it is given via rapid IV. because rapid IV is going to liberate histamine. Due to liberation of histamine, flushing, it is going to cause red man syndrome. But this might be your next expected question. Vancomycin analog. Yes, yes. Yeah, these nomograms, those nomograms, we have so many nomograms. That's what I already told you. Like that was like a 1980s things. Forget about those part. Those things not required for us as of now because we are focusing only on very high yielding points. Those kind of things will be there. Those kind of things will be there. No worries. Those things we are covered in regular notes actually. That's fine. So here comes a next expected question for you in what you call related to vancomycin. There is one drug, teicoplanin. This is a vancomycin analog. This is what? Vancomycin analog. What is this teicoplanin? It is associated with less flushing, or like I can tell you, Redman syndrome with less ADRs. Less Redman syndrome, less nephrotoxicity, less ototoxicity. So teicoplanin, this might be your next expected question because he has asked everything about vancomycin except this one. Might be coming INICT or maybe in May or November. Definitely this question will be there if he wants to ask about this vancomycin part. That's all about these vancomycin related points. Now let's come to this part, pseudomembrane colitis, again a very important. In your exam, if you see these whitish yellow plaques in colonoscopy, so pseudomembrane colitis means a white yellow plaques, whitish yellow plaques in colonoscopy. Sorry. That's what you call pickup line for pseudomembrane colitis and treatment protocol for pseudomembrane colitis. If it is primary pseudomembrane colitis, remember it is oral. Oral. Generally, vancomycin we give IV, but we give here oral because yes, fantastic, fantastic, ma Hariharan. Oral vancomycin because it has very poor bioavailability. It will not get absorbed. We also don't want it to get absorbed because it has to act in the intestine only. Vancomycin and fidaxomycin. This is like a macrolide. But in your question, if he says recurrence, but it is an initial recurrent, then go for fidaxomycin greater than vancomycin. Next, if in recurrence, if he says multiple, then go for vancomycin. Next one, if he says fulminant very dangerous, go for oral vancomycin along with IV metronidazole. IV metronidazole. Fantastic, fantastic. So it is oral vancomycin along with IV metronidazole. That's what about pseudomembrane colitis points and this relevant what you call points treatment protocol. So that's all about the pseudomembrane colitis. Now let's come to a very important one. This one might be again expected graphical representation. Aminoglycosides we have to give via OD or we have to give via TID. TID, because the reason why it is important means generally what we will think, if we give three times after giving this kind of graph, so what we will think, very for a very long period of time it is in the very high threshold value, like greater than the threshold value, so it might be causing high toxicity. That is what generally we think. That is what generally we think, because for it's almost reached 30. It almost reached 30 microgram per ml. But if I give three times daily, it is maximum reaching 10. That's what generally we think with just our common sense. But if you go in depth into that graph, clearly it shows it is what the threshold level, toxicity threshold level, that we want to keep this aminoglycosides below the threshold level. So if I give once daily, that is in the red color, if I give once daily, so maximum it will be up to maybe 12 hours only. Maximum maybe up to 12 hours or 10 hours. I can tell you 10 hours only. It is above the threshold. So above the threshold, it is only for 10 hours. Let's take it like 10. 10 hours only above the threshold. But if I give three times, almost like here you see, Almost, it's almost 7 hours. Here 7 hours, here 7 hours, 7 hours. So if I give TID, it will be almost like 21 hours above threshold. Here it is only 10 hours above threshold. So we prefer OD. We prefer once daily. Amino glycosides given once daily. Why once daily, sir? Because the threshold level is less when compared to the toxicity threshold level is less when compared to TID dose. That is what a graphical representation question he might be asking you, which of the following statements are true or false about this graphical representation. Next one, very important, aminoglycosides are going to cause nephrotoxicity and ototoxicity. These nephrotoxic, high risk nephrotoxic drugs, that is neomycin. Neomycin is a high risk nephrotoxic drugs. Next, it is when come to ototoxicity, it is going to cause cochlear damage as well as vestibular damage. So we know cochlea, if it damages, it leads to what? Deafness, but deafness is not a primary initial feature. That's what I told you. Just remember tank. If you remember tank, so here tinnitus, yes, yes. First tinnitus will be there. First tinnitus will be there, followed by headache. First tinnitus. So T means tinnitus followed by headache. This is what are symptoms that appear in a sequence. Tinnitus followed by headache. But if he goes little bit in detail and he asks you what type of tinnitus, high frequency. High frequency. But still, if he goes, so tinnitus followed by headache caused by what drugs? ANK drugs. What are these ANK drugs? These are the high risk drugs. Amikacin, neomycin, and then kanamycin. These are the high risk drugs. High risk drugs. Yes, fantastic, Hariharan. That is vestibular toxicity. That is streptomycin. Along with streptomycin, we have gentamicin also. Streptomycin and gentamicin. These are the two drugs which causes vestibular toxicity. But vestibular toxicity, we know loss of balance, ataxia will be the feature. But no, the first thing will be headache, headache followed by ataxia. This is what are symptoms for vestibular damage, and these are the symptoms for cochlear damage. Cochlear damage. That's all about aminoglycosides. We are done with aminoglycosides, the most common, highly important, high points. Yes, yes, yes. Fantastic. That's all. Now come to the next one, anti-tubercular drugs, HIV drugs, at most important one, and everything about this TB and HIV is asked in the exam, almost most of the points. Let's see this image based thing. This is what a tuberculosis, what you call representation, like a cell wall. So here chances are there he might be focusing on, not chances, it was asked also. So he will be focusing on one structure and he will be asking you which of the following drug inhibit this one, and he will be asking you which of the following drug which the drug X inhibits this structure in the cell wall, and which of the following statements are true about that drug. So those kind of things. So very easy way. So if he gives that structure of TB, just remember MAP. M means mycolic acid, A means arabinoglycans, P means peptidoglycans. So forget about the peptidoglycans. We don't want to learn about that part. So our focus is only on these two. So remember, from the structure, top will be mycolic acid. Definitely there will be clear demarcation. This is what mycolic acid, this is what arabinoglycans. Clear demarcation will be the, remember, map. Mycolic acid, arabinoglycans will come. So first mycolic acid, next followed by arabinoglycans. Now, that mycolic acid synthesis, that is inhibited by what? H, that is isoniazid, and Z, pyrazinamide. These are the two drugs which inhibit mycolic acid. Mycolic acid. HZ, fantastic. Next, arabinoglycan synthesis. This is inhibited by E, ethambutol. Fantastic, fantastic, Yuvraj. Uh, Ethambutol. Next, hepatotoxic drugs. In the first line, what are the drugs which are hepatotoxic? H or Z? HRZ are hepatotoxic drugs. Hepatotoxic drugs. Next, drugs increasing the uric acid. Drugs increasing the uric acid. Z and E. Pyrazinamide and ethambutol. Fantastic, fantastic. Harini, fantastic. Pyrazinamide, Harini, and ethambutol too. So that's all about these drugs, anti-tubercular drugs. So we have done with all these things. So just we'll see one more. Rifampicin, how it is going to act. It is going to inhibit RNA polymerase. It is going to inhibit RNA polymerase. That's all. That's all about the mechanism of action. Yes, yes, RNA polymerase inhibit. Fantastic, ma, fantastic. So that's all about these anti-tubercular drugs. And in vital capsule, I have given in detail about all the points, which we'll be discussing in vital capsule session 2. So that's all about these anti-tubercular drugs, structure, and how it is going to act. That's all about these anti-tubercular drugs. So clear with this, what you call still 32 images, everyone. So 29, 30, 31, 32, this page. If yes, we'll go to the next one. Okay, okay, okay. Okay, Alex. Okay, Sivaranjani. Okay, fine. Okay, Mananda. Okay, Bharat. Thank you, thank you. We'll go to the next part now. We'll go to the next part now. HIV again, at most important one. So chances are that he might be asking you, he will be giving you that replicative cycle, he will be focusing on something else, and he might ask you which of the following drugs inhibit this step, which of the following statements are true about the drugs inhibiting this step. So I'm not going in detail into this replication because already we have done. So finally, this reverse transcription and this integration and this maturation. These are the three main steps, and the drugs inhibiting this reverse transcriptase are reverse transcriptase inhibitors and integrase inhibitors, and maturation are protease inhibitors. And all the points related to these, things we have already done in a vital capsule part. Now let's see what are the main important points related to this one. So here the first utmost important in HIV antiretroviral drugs which are useful for the treatment of hepatitis B. So I already told you can just remember with the pneumonical lead drugs. Let them treat, no? Let these HIV drugs treat hepatitis B also. Let them treat lamivudine, emtricitabine. Very important ma this part. And tenofovir. That's all. So these are the antiretroviral drugs which are useful for the treatment of hepatitis B. Let these drugs treat hepatitis B also. Let these HIV drugs treat hepatitis B also. Next, the drug which is associated with nail hyperpigmentation. If you see in your question, Zidovudine, fantastic Jitu, Zidovudine. If you see HIV drug related to nail hyperpigmentation, go for Zidovudine. And we know all protease inhibitors, they need some boosting regimen. So what is the protease inhibitor which is used as which is a main component of boosting regimen? As already I told you, we need a right person to boost us. We need a fantastic. We need a right person to boost us. That is ritonavir. We always want a right person to boost us, right? Ritonavir, fantastic, very good. Next one. And all protease inhibitors, they need this ritonavir, but except one drug, the last one, protease inhibitor doesn't need a boosting regimen. That is nelfinavir. Fantastic, dear. Fantastic. Nelfinavir, Lavanya, very good. Fantastic. The reason why means this ritonavir is the one which is going to inhibit CYP3A4. But this nelfinavir, all the protease inhibitors are the substrates of CYP3A4, but this nelfinavir is the one which is metabolized by CYP2C19, predominantly compared to 3A4. That is the reason why we can't give ritonavir. Even if we give also, nothing is going to happen. Fantastic, ma. So that's all about this protease inhibitor. The main component is ritonavir. We want a right person. We need a right person to boost us. So boosting regimen is ritonavir. And the protease inhibitor which doesn't need a boosting regimen is nelfinavir. Next one, the protease inhibitor associated with intracranial hemorrhage. associated with intracranial hemorrhage or bleeding and highest risk of hepatotoxicity. That is tipranavir. Fantastic. Tipranavir. These HIV drugs and anti-tubercular drugs, fantastic, fantastic. Anti-tubercular drugs, you need to learn the ADRs. Very, very, very important about this ADRs. He'll be giving ADR and he'll be asking you what is the causative agent. That is what you should definitely know. So that's all about antiretroviral drugs. Now come to a very important one, newer entities, these antiretroviral drugs, entry inhibitors. So before going to the drugs, and this is what exact question also I think they have given, Maravirak, I think so, in this recent INICT November 2024. So these drugs we have, how they are going to act. Let's see it now. This is what a picture is, what a virus which is having GP41 and GP120. GP120 is a knob-like structure. What it does, it connects. It connects what? Connects the virus to our human cell, host cell. And what this GP41 does, it is a stalk-like structure. What it is do, it will help for fusion. It will help for fusion. It will help for fusion, right? Fantastic. Now this a virus will come and will attach to the our cells, which contains CD4 receptor. It is a main, and we have co-receptor also, which is CCR5 or CXCR4, depending upon the cell. Main one is CCR5. It is a co-receptor. Now we have these drugs. We have these drugs. These are the two drugs which is affecting host cell, which is acting on host cell, and these are the two drugs which act on virus. Fantastic. Now let's see ibalizumab. This is what I told you. Ibali, Indonesia and Bali. These are the two places where it is like an island. Island means 4 sites water. Fantastic. So 4 sites CD4. 4 sites Indonesia. Bali has 4 sites water, right? Next, Maravirak, CCR5. They are going to act against CCR5. Next one, fostemsavir. Fostemsavir, the name itself, it is ending with a vir, that is an antiviral drug. And stem, what a stem does, stem is the one which connects, roots to the branches. So here also I told you this GP120 is the one which is going to connect. So fostemsavir, stem connects, so GP120. It is going to act on GP120. Fantastic. Rado. Okay, Hariharan, very good. Next one. It is what? Enfuvirtide. Again the name vir. It contains, it is an antiviral drug. And what it is doing? It is inhibiting entry or it is inhibiting fusion. Entry or fusion. Fantastic. GP41. Entry or fusion is done by GP41. That's all. Just the name, how it is going to act. That's it. Nothing much is required. Not at all required all the other points. Just how it is going to act. That is more than enough. You will be reading all these things in your junior residency for 3 years and 1 year senior residency. If you go for super special, you will be reading all these things. But as of now, for cracking the exam, to attempt these questions, this is more than enough for MBBS level. So that's all about these antiretroviral drugs. That's all about these antiretroviral drugs. Now come to the next one, antifungal drugs. So antifungal drugs, again a very important, these antifungal drugs. Let's see. These antifungal drugs, this is what a cell wall structure. Here the main component is ergosterol. That ergosterol, how it is forming? It is formed via squalene. Squalene converts to squalene epoxide with the help of one enzyme, that is squalene epoxidase. So finally it forms squalene. Squalene, there are so many reactions. Finally it is formed lanosterol. Lanosterol forms a ergoster with the help of one enzyme, that is 14 alpha D methylase. Now here comes the drugs which inhibiting squalene epoxidase and drugs inhibiting this 14 alpha D methylase. 14 alpha D methylase inhibited by azoles. Squalene epoxidase inhibited by terbinafine. That's all. He will be focusing on these things and he will be asking you which of the following drug act at this step. Terbinafine, squalene epoxidase, and azoles. Fantastic, Magokul. That's all. Terbinafine, Rado, fantastic. Priyanka, very good. Terbinafine, that's all. And all azoles, all the azoles that are getting with a fluconazole, itraconazole, voriconazole, all azoles, posaconazole. Next one. Here you see one more thing. In the cell wall, this is what in the cell membrane, this is what like kind of a pore. So through this pore, everything will go out. Everything will go out. So what the drug which makes pores inside the cell wall, that is the drug which producing pores is amphotericin B as well as nystatin. These are the drugs which produces pores. Pores. Fantastic, fantastic, ma. Prakash, fantastic. Next one, fantastic. Archana, nystatin, both. Yes, good Dia, good Dia. Gopal, good, good, good. Priyanka, good. Next one. There are something which forms these see here you see this is what a beta glucans. That beta glucans are synthesized by beta glucan synthase that is inhibited by echinocandins. Newer drugs. Of course, candins, they are used for the treatment of candidiasis. Fantastic, fantastic, Suresh. Mehla Suresh. Okay, fine, fine. Sivaranjani, very good, very good, very good. That's all. That's all about these, what you call antifungal drugs mechanism. So chances are there he might be asking you these kind of picture and he'll be focusing on something, asking about the drugs. So that's all. Next, come to the relevant points. Very important, aspergillosis, drug of choice is oriconazole. Invasive, just remember A. If you remember, if you reverse the A, it will be V. Oriconazole. Right? Dermatophytosis. Dermatophytosis, fantastic, Priyanka. Terbinafine. Terbinafine. Second option will be itraconazole. First option always be terbinafine. Terbinafine. Next one, candidiasis. Candidiasis, always the first line drug will be candida. That's what I told you. Echinocandins. Disseminated candidiasis, echinocandins. But most commonly we'll be using fluconazole. But if you give both options in your question, go for echinocandins only because they are the first line drugs. First line drugs, but they are given IV. So in all scenarios, we not require parenteral admission. That is the reason why we go for fluconazole. But if you give both, go for echinocandins. But already oral thrush, we have already discussed, that is clotrimazole. Clotrimazole. Remember one thing: if you give any CNS infection in your question due to fungus, give amphotericin B. Amphotericin B will be there. Fantastic, fantastic, ma'am. Amphotericin B will be there. That's all about these antifungal drugs. That's all about these antifungal drugs. Now let's come to the next one, bull's eye maculopathy. See, it's like a very neat, clear one. It's like a bull's eye. A bull with a two eyes, it is watching you. Hydroxychloroquine, fantastic, Swati, fantastic. Hydroxychloroquine. That if you see in your question, any rheumatoid arthritis case, because this hydroxychloroquine we give in malaria for only for 5 days or like 3 days, right? So very short duration of it. In that short duration, you are not going to get this bullseye maculopathy, but this is seen if this hydroxychloroquine is given for a long period of time, that is especially in rheumatoid arthritis condition. So in those scenarios, you will see this bullseye maculopathy that is due to hydroxychloroquine. Hydroxychloroquine upon long-term use. Next one, a very important anti-malarial drugs. Anti-malarial drugs having gametocidal effect and drugs used for radical cure. First, we will see this radical cure. The drugs producing radical cure. Primaquine, fantastic one. Primaquine, good, good, Priyanka. Then there is one tafenoquine. It's analog. Newer one, tafenoquine. Primaquine, tafenoquine. These are the drugs useful for radical cure. Fantastic. Now, the drugs having gametocidal effect, the same, primaquine, tafenoquine, and along with that one artesunate compounds. Artesunate compounds. That's all. Very important. Fantastic. Hariharan. Good. Good. So gametocidal effect primaquine, tafenoquine along with artesunate. Remember the radical cure means only primaquine, tafenoquine. Gametocidal means generally people will go for only primaquine, tafenoquine, but it is a multiple thing like which are the following or like having gametocidal effect. He will be giving 5 and like 1, 2, 3, only 1, 2, only 1, 3, 5, something like that. So go for artesunate also. Artesunate also. That's all about these few things related to this malaria. And in vital capsule, we have given malarial treatment, rest of India, northeastern states, Plasmodium falciparum, Vivax, mixed one, everything we have given in this vital capsule. You can go through there, but it is like kind of image based one and quick recall of all the important points. That's all about these bull's eye maculopathy. So clear about this page up to 36. Uh, is everything clear? I don't know what page it is actually. Yes, okay, Alex, okay, Jitu, right? Stress, okay, Ma, Sivaranjani, fine. That's all. Now, question number 31. My notes given as tinnitus followed by hearing loss for a cochlear damage. So, cochlear damage, tinnitus follow. Oh, sorry. Sorry, it's hearing loss only, man, not a headache. It is hearing loss only. I think I told that hearing loss, but I have written headache might be. It's hearing loss only. Obviously, cochlea means hearing only. No, extremely sorry. While explaining, I told hearing loss, but I think I writing I have written headache. So tinnitus followed by hearing. Thank you, ma, Richard. Hearing loss only. Obviously, cochlea is only for hearing only. No, that's part. Clear? Thank you for correcting me. So, can I go to the next one? So we have done with antimicrobials. So we have done with antimicrobials. Now we'll go to endocrine. We have three things. One is endocrinology and anti-cancer we have, and the last one is like I think we have only some 6 images left. 37th, yeah, six images are left. We can finish it off in just maybe 20 minutes, something like that. So insulin. So here in this endocrinology, very important, at most important one is insulin, anti-diabetic drugs, at most typical anti-diabetic drugs. So we'll see one by one now. So if you give, if you get this, if examiner gives such kind of graph, and if he may ask you focusing on this part, this part, this part, which of the following statements are true? Chances are there. Here, if you see the graph on x-axis, we have taken a duration, we have y-axis, I have taken intensity of action. If you see anything which is close, very simple one, the group of insulin which are close to y-axis and group of insulins which are close to x-axis. Close to y-axis are called rapid acting insulins. Rapid acting insulins. And close to x-axis are called long acting insulins. Long acting insulins, right? And what are the other things which are present in between? So in short, all insulins I told you, we have only short acting, long acting. That's it, nothing much. In that short acting also we have rapidly acting ones, and the other one is regular insulin, and this one is NPH, neutral protamine Haig-Ton. So, but these are the two things which easily you can tell. Easily you can tell, like close to y-axis, that is rapidly acting insulins, and close to x-axis, that is long acting insulins. And is there any relevant point related to neutral protamine Haig-Don? All are crystal clear except neutral protamine Haig-Don, it is cloudy. Cloudy, this is the only one. If we give you insulin which is cloudy appearance, go for neutral protamine Haig-Don. Okay, fine. Regarding this short acting, this is what classification. All insulins are divided into short acting and long acting one. Insulins are divided into short acting insulins and then long acting insulins. So this already I told you in a main class also. Long acting insulins are very easy to remember. All these are things starting with insulin, having large in its name or starting with a D. Just see insulin if followed by having a name containing large. Glargine, go for long acting. No, there is no large. Check whether it is starting with a D. If it is starting with a D, then also go for it is a long acting. If not, there will be a short acting. So what are the short acting insulins? Lispro, Aspart, and then Glulicin. Lispro, Aspart, and Glulicin. These are the short acting insulins. So clear, short acting and long acting. Now, these long acting insulins, these are also known as peakless insulins, because if you see here, for all these things we have peak, but here there is no peak. There is no peak here. That is what we call peakless insulins. So what are the relevant points related to these peakless insulins? Nothing much. They are the drugs which are soluble in acidic pH. That is what the important. That is the reason why they are soluble in acidic pH. That's all. Soluble in acidic pH. Nothing much. Next one, among these long-acting insulin, which is having the longest duration of action, D-gludac. This is having longest duration of action, almost 40 hours. Almost 40 hours. Almost 40 hours. So that's all. Now, let's come to the oral drugs. Oral drugs. Anti-diabetic drugs. Now you tell me anti-diabetic drugs indicated in heart failure. See here, very clear, it is indicated in heart failure, contraindicated in heart failure. Indicated in heart failure are the drugs which are SGLT. Fantastic, Priyanka. Those are gliflozins. They are nothing but SGLT2 inhibitors. Next one, flozins. Fantastic, Gokul. Next one, Amrita. Very good. Next, contraindicated. Contraindicated in heart failure are, already I told you, PPAR gamma agonists. They are pioglitazone. Fantastic, fantastic. They are glitazones. They are nothing but glitazones. Pioglitazone and rosiglitazone. Glitazones. Next one, the drugs. This was a question asked multiple times in the exam, associated with urinary tract infection. Fantastic. It is like again SGLT2 inhibitors asked multiple times in the exam. Gliflozins, all SGLT2 inhibitors. These are drugs which causes urinary tract infection in females. That's fine. Very good. Now let's see a few things. Metformin, most common ADR. Of course, on long term, it is going to produce a vitamin B12 deficiency. In rare cases, it is going to produce a lactic acidosis, but what, fantastic diarrhea, fantastic. GIT intolerance, GI side effects, fantastic. GIT ADS, that is GI intolerance, diarrhea, cramps, and all those things. This is also the, because metformin is a most commonly used drug. As already I told you, most common things or most commonly used thing you should know in detail. So this is what the question they have asked. I think 2024. I think May. I think so. May INA series they have asked this question. Metformin most common ADR. But chances are there he might ask you, as it is causing GIT intolerance, how to decrease it, because this is the most commonly used one. The GIT intolerance that can be decreased by sustained release preparations. Sustained release preparations. That's all. That's how you will be seeing a metformin SR 500, metformin SR some 1000, something like that. So, or like 250. So, metformin SR means sustained release preparation. To avoid this one, we'll be giving sustained release preparation. This might be your expected thing in the coming INICT this year, 2024, May or November. They might ask this kind of question. Sustained release preparations. That's all about this insulin part. That's all about this insulin part. Now come to the next one. Anti-cancer drugs. Anti-cancer drugs. So in anti-cancer drugs, we have few things here. We'll discuss one by one now. In anti-cancer drugs, so cell cycle specific kind of drugs. Let's see what drugs acting on which cycle, which cell cycle.